Dr. Brandon.
How are you, Dr. Morgentaler?
I'm great. What a pleasure to see you again.
And you as well. I understand we're talking about erections today.
Not just erections, but erections and testosterone. And here's the
Right.
key question. The question is testosterone an adequate treatment for men with erectile dysfunction?
Before we start, a small disclaimer. The Sex Doctors podcast is not a substitute for medical or psychological advice.
So it's an interesting question, and I would just kind of assume the answer would be yes, but I suspect it's not that simple.
Well, so the answer is it kind of depends. But what really got me wanting to talk about this today is that I'm on this. We used to call them listservs. I'm on this email list, right, with about 20 something different urologists and sex experts from around the world. And testosterone came up, and one of these world experts wrote that testosterone isn't good for erections because of data from the Traverse study. So we've talked about the Traverse study, the largest randomized control trial done to date, over 5,000 men randomized to testosterone gel or placebo gel, 33 months of average follow-up. And what the Traverse showed is that sexual activity increased a lot, libido increased a lot, but erections were no different between testosterone and placebo. And so he writes, well, you see, testosterone isn't any good for erections. And it makes me crazy because that is what the study showed,
Hmm.
but there's reasons for it. And it's not just him. I mean, this misunderstanding about testosterone and erections is widespread
Hmm.
everywhere.
So it's typical for professionals to think that testosterone does not help with erections.
Well, let me tell you how typical and how bad it
Yeah.
is. So, this is from the American Urological Association, the AUA, from their guidelines in 2018 on erectile dysfunction. I'm going to read it.
Hmm.
Men should be advised that testosterone therapy is not, I'm going to add for emphasis, is not an effective monotherapy for ED. And for those of you who don't like jargon for medical jargon, means you shouldn't use it alone, monotherapy. If the
You
man's,
could use it alone, but not for this purpose. Right.
yeah,
Yeah.
not for ED. If the man's goal is amelioration of ED symptoms, make it better, then he should be counseled regarding the need for ED therapies in addition to testosterone therapy. Now, here's the thing. I know many of the authors of those guidelines. They're my respected colleagues. I like them.
Mhm.
But um, guys, you're wrong. You're-
Should we publicly shame them? You could list their name.
No, no, no. But you have to understand this is nonsense. And it's nonsense because people don't understand testosterone's role, how it works,
Mhm.
and they don't understand testosterone deficiency. And let me try and explain it.
Okay,
May I?
please.
So listen, so for a guy to have a good erection, he needs a few things to be working well. One is he has to have adequate testosterone levels. He has to have nerves that connect the brain to the penis so that if he sees something arousing, thinks of something arousing, smells something arousing, the signal goes to the penis to work.
Mhm.
And he needs blood vessels to carry blood to the penis and also on the venous side to be able to trap the blood in the penis. We create high pressure in the erectile chambers. We hold on to that pressure. That's an erection. Okay?
Okay,
If any one of those components is off, then erections don't happen.
okay.
So if the guy isn't turned on, you don't get an erection. If the nerves are damaged,
Mhm.
maybe because of surgery, like for radical prostatectomy, doesn't matter how turned on the guy is, doesn't
Mm.
matter how good his blood vessels are, doesn't matter his testosterone, it's not going to work.
Mhm.
So the main thing we're talking about in most people who don't have an obvious cause, like surgery for prostate cancer, is blood vessels
Mhm.
versus hormones. And by hormones, I mean really specifically testosterone. So,
So you're saying that most guys can find some way to get turned on, and they have communication between their brain and their
so
penis.
if I've got a 50-year-old guy who comes and sits in front of me in the office and his main complaint is his erections aren't good,
Mhm.
I don't really know for sure, sitting with that guy, how much of his problem is likely to be hormonal,
Uh-huh.
even if he has low levels of testosterone,
Mm.
or how much of it is vascular.
Okay.
Okay, so here's what happened in the Traverse trial. What they did is that the main purpose of the Traverse trial was to prove or disprove, to address the concerns the FDA had from 10 years previously, that there were concerns raised that testosterone was bad for the heart,
Uh-huh.
caused increased heart attacks, strokes, and death. And so they made the testosterone manufacturers design a study under the guidance of the FDA to look at cardiovascular events with testosterone versus placebo. In order to do that, you need a lot of bad events,
Yeah.
heart attack, strokes, and death. In order to get a lot of bad events, you need men who are predisposed to having events, which means men who, and to be in the study, had to either have known heart disease, prior heart attack, prior stroke,
Hmm. Mm-hmm.
or you had to have not one, not two, but at least three important risk factors
Wow.
for heart attacks or strokes.
Mm.
Things like diabetes, high blood pressure, high cholesterol, high triglycerides, things like that.
I see
S-
where you're heading
Yeah.
with this,
So,
Dr. Morgentaler.
so this was a super high risk group with a lot of what we would say vascular burden, cardiovascular burden. And in these guys, it makes complete sense that they didn't get an improvement in erections
Mm-hmm.
because they had bad blood vessels. So you could make their testosterone that of a 18-year-old. It's not going to matter.
Right.
Most of those guys, now there may be some who improved. We don't get those individual data,
Mm-hmm.
but on the whole, those guys aren't going to show a lot of improvement.
Right.
Okay. Now, the testosterone trials, which was the first large randomized controlled trial that came out in 2016, they excluded everybody that would have been included in Traverse. In other words, if you had heart
Yeah.
disease or a stroke, you were not in that study.
Mm-hmm.
They wanted relatively healthy men, 65 years and older.
Mm-hmm.
And in those men who, the same design, those men who got testosterone versus placebo, did show improvement in erectile function.
Ah, okay.
In meta-analyses, 'cause there have been plenty of smaller studies that have looked at it, testosterone helps with erections.
Well, so why didn't they address that in the Traverse trial, saying that the reason this is not consistent with past research is because these guys had vascular issues? Shouldn't that have been on the authors
You
to
know,
do?
Marianne, they should have had you as one of the authors. No, seriously, because you get it. It's actually not complicated.
But it's typical protocol in your discussion, in your results and discussion to say, this is consistent or not consistent, and they speculate, authors speculate, but they didn't even address this.
Well, I don't remember it well enough to remember whether or not they said anything about that.
But your colleagues didn't read it if they did, is
But
basically.
most people don't know that. They just take the study and they say, "Here's a study."
Yeah.
You know, there's a thing that happens in medicine now, where you get a medical student to write a paper, and for them, all papers are equal. And so they just take the abstract
Oh, I
from the
see.
abstract, whatever the results are,
Right, right.
without any real deep knowledge, or not even
Yeah.
deep, without any real knowledge of what's underlying it all. And they just put together the numbers. Everybody's busy. Somebody supervises it. They read it over. It says it looks like it's well referenced, reasonable, and they pass on it.
Mm-hmm.
But what concerns me is that most urologists, and especially the folks who write the guidelines, don't understand about testosterone. So here's the thing. If anybody has experience with testosterone therapy, they've had guys who come in with ED, they've got low testosterone levels, they treat their testosterone so that it's a good number, and many, but not all of those men will come back and they'll say, "Oh my God, my erections are better. And my sex drive is better and I feel better in these other ways." Like it's a everyday occurrence
Mm-hmm.
in a practice that uses a moderate amount of testosterone.
Mm-hmm.
Like it's obvious. And for people who doubt this, they say, "Oh, that's just anecdotal." I would ask them to do a thinking experiment.
As in think.
As in think. Like Einstein did these Gedanken experiments. You think about things, right? Like a lot of the physics that he dealt with, like you couldn't get things to move as quickly, like at the speed of light as he did. So they're thinking experiments. So if you take a group of men who are, let's say in their 20s, they're perfectly healthy. And some of these men have volunteered for studies where they go on medications that lower their testosterone.
Mhm. I hope they get paid well for that.
Yeah. Well, it's temporary, and I'm sure they do get paid.
Yeah.
They do this voluntarily. But if you lower their testosterone in young, healthy individuals, they lose their sex drive, and most of them will lose their ability to have erections.
Okay.
Once the medication is stopped, which is kind of like their testosterone rises, which is a little bit like giving testosterone to people who are low,
Mhm.
and their erections all come back to where they were.
Mhm.
The entire thing was mediated by whether they had good testosterone levels or they had low testosterone levels.
Mhm.
Like it's obvious. Make sense?
Yes, it does.
Yeah. So there's no question and that's testosterone monotherapy. Those guys don't need Viagra, Cialis added back
Right.
to have adequate erections. They just needed their testosterone back.
No, I get it. They had no vascular issues.
So the problem is if we're dealing with an individual patient sitting in front of us, we don't know. We don't
Yes.
know how much of it's vascular, how much not. If he's younger, the likelihood is it's more likely hormonal if he's got low testosterone,
Mhm.
because it takes a while. Vascular disease tends to be a much more of an age-related thing. Um, but there you go. And I would just say that clinically, how I handle it
Mhm.
is that whenever I can, I try. So if I have a guy with low testosterone and erectile dysfunction, my first step always, almost always, is to give them testosterone first,
As opposed to
giving a pill like Viagra or
yeah.
Cialis.
Yeah.
And the reason I do it that way is, and I find this fascinating, is that the men whose testosterone is normalized
Mhm.
and they get a good response,
Mhm.
they feel like they're a normal guy.
Mhm.
They don't think of themselves as having ED.
Mhm. 'Cause they don't.
They don't. They had a hormone
Right.
problem
Mhm.
that's now been solved
Mhm.
that caused their ED, but they don't have ED.
Mhm.
When you interview or talk to men who have ED and we give them Viagra, Cialis, or equivalent,
Mhm.
they feel like they've got ED. They
Mhm.
have ED, even if the pills work. They're just managing their ED.
Yeah.
Psychologically, it's a completely different game.
I see.
There's another reason too, which is that a guy comes in with ED and you give him one of the pills, and let's say it works.
Mhm.
He's happy.
Mhm.
Problem solved. But most men who have low levels of testosterone have other issues going on too.
Mhm.
And if you give him the pill and it works for him, he's unlikely to want to try additional treatments.
Right.
He says, "I came to you for a problem. It's fine." It's like if you went
Yeah.
because you had a toothache to the dentist, and they says, "Well, we have this whole other thing that'll like make you rise and shine with optimism in the morning." I said, "No, thank you. You're a dentist. You fix my tooth, I'm fine."
Right.
Right? So men don't know what they're missing often with low levels of
Yeah.
testosterone until it's restored to them.
Uh-huh. That's interesting. That happens for people with mood too. When their mood's low and they're put on an antidepressant, they'll say they don't realize how depressed they were until they feel better. So same kind of thing. It normalizes the dysfunction gets normalized if you have it long enough.
Yeah. I did a study with one of my former fellows, Luis Reyes, who's now a prominent urologist in Mexico City. And we had a standardized questionnaire that we asked, questions that we asked people when they came in. They had low levels of testosterone. We asked them about erections and energy and mood, and I forget what else. And we asked them also when they came back after treatment, we want to see what got better. And we published this, I forget, somewhere around 2010. And the amazing thing to me was that the number of people who improved in some of these categories, like let's say energy,
Mhm.
was much higher than the number of people who complained about it as a problem at the beginning.
Uh-huh. Uh-huh.
because there were some people who thought, no, I'm fine in that area,
Mhm.
who didn't realize how much better they could feel.
Yeah, I get it.
It had happened over time. They just assumed it was okay. It's like the question, "Hey Joe, how you doing? How are you feeling?" Say, "Well, pretty good for my age."
Mhm.
Right?
Mhm.
Right? Let's say he's 60, 65. He's already discounted in there how good he might feel
Mhm.
based on his age.
Yeah.
I'm all right for my age. I'm okay. Like compared to my buddies, I have as much energy as them, or my golf drives, my drives at golf are as good as theirs or whatever. But a lot of people don't, and I'm not saying testosterone is good for golf, by the way. That's not what I'm saying. Or will improve your distance. All I'm saying is that we when things happen slowly, as health issues tend to do,
Mhm.
including testosterone deficiency and the impact of it, is we don't know how much better it can be. And so when I see a guy who's got ED and low T, I want them to first experience what it's like to have normal levels of testosterone. My hope, but it's not a guarantee, is that his erections will improve and his ED will resolve. If so, home run. He never needs any of the pills unless really there's a persistent problem.
So if one of our listeners feels like he's got some erectile dysfunction, maybe it's not so much that he can't have sex, but still he's concerned and he's wondering, well, could testosterone help or not? Like, what's step one for him?
Yeah, I'd get your testosterone levels checked.
Hmm.
And if you do testosterone, you have to get total testosterone and free testosterone. Low values for total testosterone, I think, are anywhere less than 350 nanograms per deciliter. In European values, that's around 10.1 nanomoles per liter. No, I'm sorry, 12.1. And for free testosterone, if it's less than 100 picograms per mil, and you got symptoms like low desire, low energy, erectile dysfunction, that's low and I think is worth treating.
Okay. Is there anything else you'd say to them um, eh, eh, that they should
If your
know?
levels are low, I would follow the recommendations that I just gave. I would see if you get started on testosterone therapy. You have to give it a few months to see about erections getting better,
Mm.
because it doesn't necessarily happen immediately. And then if it's still not better, then you can certainly add in Viagra or Cialis if you haven't tried those before.
And also, I mean, as a sex therapist, we're sort of indoctrinated with this concept that if a guy has got ED, you want them to talk to a doctor about it because it could be indicative of a cardiac issue, a vascular issue that they need to address, right? So that's
Yeah,
also,
that's true. So ED can be, because of the vascular connection, can be one of the early signs of cardiovascular disease. And in some studies, men who presented with ED, that was predictive of later on having cardiovascular disease.
later on, like 5 years, seven
Yeah,
years, it's like a long time.
I know. I'm always a little bit careful about saying that because I don't want people freaking out,
Uh
because
huh.
ED is super common.
Uh huh.
And I don't want people thinking that because they have ED, they're going to die of a heart attack in the next week or month.
Right.
But it is an indication. I'll tell you a funny story with that, which is that years ago, it was around the time, many years ago, around the time that there were issues around priests and
Mm.
sexual
Mm-hmm.
misdeeds.
Mm-hmm.
I had a lovely Jesuit priest who was a patient of mine for something completely unrelated. And after I'd seen him for a couple of years, he said, he told me that he had ED. And boy, did I really not want to get into his
Oh, geez.
sexual history. Like, I didn't want to go near that. And as it turned out, when I asked him about it, he said, well, I thought it might be information that might be valuable for you to know in case it means something about his health.
Uh huh.
He wasn't looking for a treatment,
Uh huh.
but he just thought it might be an important issue, and
He was right. Yeah.
it is. Yeah.
Sometimes you think stories are funny and they're not, that funny.
Well, I that wasn't supposed to be a
I thought you
huge.
said that as I'd tell you a funny story.
Well, funny stories sometimes get included. It's just curious. If it was funny,
Oh, I'm
it's
being too
not
concrete.
funny. Ha ha.
I see, I
Yeah,
see.
yeah. Funny
Okay.
as in,
Sorry.
yeah.
Yeah. Glad we cleared that up, though.
Yeah. Well, and I'm glad you weren't laughing.
Yeah.
All right. Well, I think that wraps it up.
Yeah, nice
So,
job.
testosterone can be monotherapy for ED. Absolute and tootin'ly. And AUA guidelines. Guidelines are good, but if you're an expert, experts don't use guidelines. Guidelines are really general recommendations for people who are not for non-experts.
And they're so broad that they sort of don't address an individual patient. They're just sort of
Yeah, and in this case, exactly. They sort of put down an edict, one size fits all.
Mhm.
And of course, there really is an art to medicine, and you have to figure out who it is that's sitting in front of you and try and dissect that out and figure out what's going on.
Right.
Great. Well, Dr. Brandon, thus ends another episode of the Sex Doctors podcast.
Thank you for your wisdom.
And it's a pleasure working with you as always. Listen, I hope to see you again for another podcast.
Oh, me too.
And I hope it's soon.
Yeah, me too.
Bye-bye.